Welcome to the June edition of the ECG 5-Minute Consult, where we walk you through the basics of ECG interpretation in a scenario-based format. It's important to have an organized approach when looking at ECGs, and for that we turn to what we call the ECG Primary Survey, that you may know from our manual ECG for First Responders. For those unfamiliar, here are the 4 questions that make up the primary survey. They are, first, is heart rate too fast or too slow, causing cardiovascular instability? Second, is rhythm supraventricular or ventricular? Third, are ST segments consistent with ST elevation myocardial infarction STEMI or non-ST elevation myocardial infarction NSTEMI? And lastly, are T waves consistent with STEMI or NSTEMI? With this in mind, let's take a look at this month's scenario. You arrive on scene to find this gentleman, who is a 63-year-old male with a history of hyperlipidemia, hypertension, and rheumatoid arthritis, who presents with chest pain. He states that the pain is a crushing pressure in the center of his chest that came on suddenly about 40 minutes ago while watching TV. He states that on a scale from 1 to 10, where 1 is just a pinch and 10 is the worst pain imaginable, that it's about an 8 right now. While you were getting the history from your patient, you obtained a 12-lead ECG that is shown here. To interpret this, let's run through our primary survey. First, we'll look at the heart rate. The fire captain on scene decides to test you by folding back the top of the ECG that would have shown the calculated heart rate, so now you have to figure it out yourself. But don't worry, we'll walk you through it. To make it easier on ourselves, let's pick an R wave that falls on a bold line of this ECG. How about right there? Now we will count the number of large boxes until the next R wave, and that is 1, 2, 3, 4 large boxes between R waves. So now if we divide the number 4 into 300, that gives us our heart rate, which is 75. So is the patient stable or unstable? Well, to answer that question, we need to get a set of vital signs. We have a BP of 140/82, the heart rate we just found to be 75, respiratory rate is 18, and temperature is 98.8 degrees Fahrenheit. He's not hypotensive, displaying signs of shock or signs of altered mental status, so he is stable for the time being. Next, we need to determine whether the rhythm is supraventricular or ventricular in origin. Though rapid supraventricular rhythms can cause hemodynamic instability, especially if sustained for a period of time or if in the presence of STEMI or NSTEMI, we want to delineate rhythm origin at this point in the primary survey because ventricular rhythms may directly lead to hemodynamic instability with decreased cardiac output, decreased blood pressure, and can quickly degrade into ventricular fibrillation or pulseless ventricular tachycardia. To see where the rhythm is coming from, we're going to look to see if these QRS complexes are narrow or wide. Now, while a wide QRS complex does not guarantee that the rhythm is ventricular in origin, there's some exceptions to supraventricular rhythms that would cause a widened QRS. In most cases where there is a wide QRS and evidence of a STEMI or NSTEMI, the likelihood in that case is that the wide complex rhythm is most likely ventricular. So let's remember that a QRS complex of less than or equal to 0.12 seconds is considered narrow, while a wide QRS is one that is greater than 0.12 seconds. So for us, this means checking whether it is less than or equal to 3 small boxes wide. And here's a graphic to remind you of the relationship between the large and the small boxes, though the grid lines on this ECG are pretty easy to see. So if we look closely, it seems that our QRS complex is easily less than 3 small boxes wide, which indicates that our rhythm is most likely supraventricular in origin. Now, onto the ST segments. Let's compare each of the ST segments to the baseline, that is the isoelectric line. We're looking for ST elevations that would indicate infarction, as well as ST depression. Now, ST depressions are associated with ischemia, but such depressions can also occur in NSTEMI. Cardiac enzymes performed at the receiving hospital can distinguish between the two, but in the field, ST depression should always be regarded as a possible NSTEMI. Now, for the sake of time, I'll click through these quickly, just so long as you understand that you want to look at the ST segments in each of these leads. Remember, a STEMI will show on an ECG as ST segment elevation in 2 or more contiguous leads, by which I mean 2 or more leads looking at the same region of the heart. We can see here that there's some pretty extreme ST elevation. And I'll clear some of this out of the way so you can see better. The ST elevation is most obvious in the inferior leads, which are 2, 3, and AVF, but there's also ST elevation in the lateral wall leads that are V4 through V6. This suggests an inferior wall infarction that involves the lateral wall of the left ventricle, making this an inferolateral wall myocardial infarction. Kind of a mouthful, I know. There's also some ST depression here in AVR, AVL, V1, and V2, which may be reciprocal changes. So no surprise that these ST segments are abnormal. Lastly, let's take a look at the T waves. The T waves are normally upright in all leads except for AVR and V1. We can see that the T waves in AVL and V2 appear to be biphasic. As far as T wave inversion goes in STEMIs, they may or may not be seen early on. They may be buried in ST segment elevation. They may not have occurred yet. So while we consider these to be abnormal for now, please note that the ability to accurately assess T waves is greatly impaired in the presence of significant ST elevation or depression. Now that you've properly examined the patient, appropriately obtained a 12-lead ECG, and gone through your primary survey of interpretation, you're ready to roll. But your patient doesn't want to go despite his symptoms and his family's insistence. So what action should you take? A. Transport despite his wishes. B. Have family transport if he's willing. C. Advise that if he changes his mind, call EMS again. D. His ECG is normal, he should follow up with his primary care doctor. Or E. Tell him he's having a heart attack requiring urgent medical attention. I hope you answered E. This man's having what appears to be an inferolateral wall MI. He needs to be transported to the nearest STEMI receiving center right away for percutaneous coronary intervention, PCI, in a cath lab. On a side note, it's easy to get in the habit of administering what we call MONA to our chest pain patients. That is morphine, oxygen, nitroglycerin, and aspirin. But please be aware that there is a relative contraindication to the use of nitroglycerin in patients having a right ventricular infarction. Though this seems to be an inferolateral wall MI, it is important to note that inferior wall MIs involve the right ventricle 30 to 50% of the time. Now, the problem with nitroglycerin in MIs where the right ventricle is involved is that it causes peripheral vasodilation, that is, peripheral pooling of blood, which essentially reduces the preload, or in other words, it reduces the volume of venous return, thereby reducing the end diastolic volume, which decreases the stroke volume, resulting in decreased cardiac output. I apologize if I put anyone to sleep with that explanation. Physiology is a very heavy subject. On the other hand, if you're a huge nerd like me and find this stuff interesting, then I encourage you to look up the Frank-Starling law of the heart, and maybe even glance at the formulas used to calculate cardiac output, stroke volume, and all that, as it will deepen your understanding of how the cardiovascular system works. We hope you've enjoyed this edition of the ECG 5-Minute Consult. Be sure to tune in next month for another case. See you then.